Great. So I think we'll begin. So very excited to have Allison Hoffman here with us today. Allison is a professor at Penn and a really premier expert on healthcare law in the United States. And I'll be talking a little bit about pharmaceuticals. Allison will talk more about healthcare and health insurance, and framed all through the lens of the questions that we're asking in this course about anti-monopoly and regulated industries. So let's take just a few minutes to connect up our conversation with other things we've been talking about over the course of the semester. So as is commonly the case, today we'll be talking about healthcare and pharma with examples drawn from the United States, but the lessons that we're talking about, I think, will also give insights into other dynamics and systems, things going on elsewhere around the world, in part because some of the drivers of the monopoly problems and the concentration issues and the regulatory issues are similar in many places, although, of course, the regulatory environments differ very substantially in healthcare as in other things. But I think we'll be talking about and learning things about the toolkit and the problems that can be extrapolated in certain ways to other parts of the world. So one question is, why do a session on healthcare and pharmaceuticals? Obviously, we're talking about a major sector of the economy. In the United States, healthcare employs 11% of all workers and is 24% of government spending, and 19% of total GDP. Pharmaceuticals are, of course, only a subset of that, but according to some estimates, 10 to even up to close to 20% of healthcare spending, depending on how you measure it. But the more important reason, I think, is that healthcare and pharmaceuticals are clearly part of the rising concentration and private power story that we're talking about. And so understanding how law has shaped this context and how we might respond to sort of build a more egalitarian environment is important to the broad project of the AMRI course. So we'll touch on this, but just to say, consolidation in hospitals has been clearly documented and shown to impact both prices and wages, perhaps accelerating, as you saw in one of our earlier readings, after the pandemic. So these are sort of basic markers of the connection between healthcare and anti-monopoly ideas. Pharmaceuticals are given monopoly power via patents and regulatory exclusivities, and that results in both pricing problems and supply problems and shortages, as well as I'll talk about, both wasteful and misdirected innovation. The regulatory ideal, actually, in both contexts, has been organized around choice, often in the United States, but as you saw in your readings, and as we'll be talking about, that has actually created its own set of problems and really sort of failed as a regulatory ideal. So we'll touch upon over the course of this hour why there's growing private power in this context. And I think what we'll see here is common to what we've seen in other contexts and industries that we've talked about, that you have a highly regulated sector, a sector full of essential goods, and that's also highly informational, lots of returns to scale, network effects, and lack of attention to, or in certain ways, modifications of the law in ways that have enabled consolidation, and a regulatory environment that has not served consumers particularly well, means that we do have less and less kind of effective competition and more consolidated power, and lots of failures of the sort of neoliberal paradigm that we'll be talking about, and that will intersect with other ways that we will be thinking about over the course of this whole course. So one reason we wanted to talk about it then is, of course, that it's an illustration of and an exploration of these anti-monopoly dynamics and concerns. Another reason is that we wanted to be able to think about the regulatory toolkit very broadly. And so, as we've talked about in other contexts, although people sometimes think that anti-monopoly traditions lead you directly towards breaking things up or structural remedies, increase of competition, in other contexts, we see that there are reasons to consider things like public options or even public provision, or in this context, what we'll call single payer. So we'll be thinking about the regulatory toolkit with healthcare in mind as an example that might lead us more toward considerations of government provision, for example, than some of the other areas we've talked about. So let me pause there and turn it over to Allison with great thanks.
Well, it's a pleasure to be here today with you, Amy, and to talk about healthcare and pharma. I'm going to share some slides and we'll get us kicked off. And hi to all of you. I look forward to seeing you soon for our in-person discussion. So what I'll do today is I'll provide a little bit of background on health insurance for those of you who are not already steeped in the topic. And then I'll talk through why competition hasn't worked well in this space, why the traditional tools to regulate haven't worked all that well, and what the alternatives might be. So let me start with just a really basic introduction to health insurance. I know for those of you who know a lot about health insurance, this will be review. But for those of you who don't, hopefully this will help you understand kind of the ideological conflict underlying and the values underlying questions of health insurance regulation in particular and healthcare policy more broadly. So why do we need health insurance? This is my favorite picture. Some of my students are taking the class this summer and they've seen it already. And so this is my favorite picture because what it shows is this is the curve of healthcare spending. So if you look along the bottom, the x-axis, it's the total US population ordered by health expenditures. So, you get to 10, that's 10% of the population, and the middle is 50% of the population, all the way to the right is 100% of the population. And then as you go up, it's percentage of total healthcare expenditures. And so what you see is that about half of the population spends nothing on healthcare in a year. And then as you get over to this kind of right-hand side, you see that about 10% of the population is responsible for about 70% of the costs. And so what that means is, and I should say that 10%, those high spenders change year to year. They're not always the same people. And so if we had to pay for healthcare out of pocket, if each of us had to pay for what we need in any particular year, those of us who end up in this kind of high end of spenders in a year wouldn't be able to afford that cost. So health insurance is the mechanism to help smooth this spending. Now, that's the broadest conceptual description of it. The hard question is, how do you smooth that spending, and what kind of spending do you smooth? That is the heart of it. I mean, that is the core of the conflict underlying questions of the ACA and of Medicare and of Medicaid and private health insurance regulation is who's going to share in spending with whom, and what spending are they going to share in? And so at one of the most basic questions is, it is this question of who's in what we call a risk pool, who's sharing costs with whom. And I've given you a visual depiction to show the extremes of this, right? So on the left-hand side is this individual. And the way that I usually describe this is we could think about distribution being just at the individual level and over time, intertemporal distribution. So health insurance might work so that it spreads my spending over my lifetime. I pay premiums, I pay a certain amount every year, and I take out in those years where I'm one of the spenders. And in the years where I'm not one of the spenders, I'm essentially kind of building up my coffers for the years when I'll need them. And so that is kind of, a perfect individual risk-adjusted notion of health insurance. They look at me, they say, we think you'll need this much in your lifetime, and so you should pay in this amount, and we'll spread those costs for you. Now, the opposite extreme is my picture with all the people on the right-hand side. And this is interpersonal distribution of costs. And the idea there is that, this year we're all going to pay into the pool, and some of us will need it and some of us won't. And if we're lucky, in fact, over our lifetime, I will never take out the money that I pay in. And so what will it do? It will pay for healthcare costs for others. And so you can go back to this picture and think about, what does it mean on this kind of graph? It means that you would take up all those costs underneath there, and we would each pay in to finance them. We could each pay in $100 a month, or maybe you base it based on income. And then the people who need it in any particular year, they take that money out, and those who don't need it. And so that's, kind of in something like, a Medicare for all kind of system. If every one of us were on Medicare, we would all pay into the Medicare system through taxes or some other format. And then the people who need health care would use it. So that's kind of the basic that's my third question, is the who pays and on what basis. But and in addition to that, you also see controversial questions around, what does health insurance cover? What kind of benefits should be covered? How much should people have to pay each time they go to the doctor? Or how much should they have to pay before their insurance starts to pay, and a deductible? And so it's these questions of, what are the benefits? Right now we hear a conversation around Medicare, whether it should cover dental and vision. It's just one of these many questions is, should we share the cost collectively of dental and vision, or is that something that people should bear individually or have to manage on their own? So every time you see a health policy decision, you see health insurance regulation, the Affordable Care Act's determination of what are going to be the quote unquote essential health benefits, what health plans have to cover, rules that it put in place about the fact that policies couldn't tap out at a certain point. There could be no lifetime limits on how much your insurance policy would pay for. These are all questions of what is under that umbrella of insurance. So now, if we think about the space of private insurance, I'll talk today about private insurance and public insurance, how they're different. And if we think about the space of private insurers, if they were operating in an unregulated way, what they would try to do is get as close to that picture on the left as possible. So they would look at me and say, okay, you're kind of middle-aged, you're reasonably healthy, we're going to charge you on that basis. And I'll say, okay, that seems fair, and I'll buy insurance on that basis. And they would look at somebody, some of you on who are watching this, and they would say, okay, you're 25, 30 years old, you're healthy, we're going to charge you less. And so they try to get to this version of charging me exactly what I'll pay in over time, and in the theory that that's going to make them more competitive, and I'm going to want their product more. Now, it's impossible to do that, because it's impossible for them to even if they ask me a lot of questions, to know exactly what's going to happen to me over the course of the year. That might require health spending or not, but that's what they try to do. So if you look at the pre-ACA world, before insurers were regulated, especially in the individual space where individuals were buying on their own, this is just an example of, this is from an underwriting guide from a real insurer. And it said to their underwriters, they're people who would ask people about their health, when do you deny insurance to people? You always deny insurance if somebody has one of the top conditions. They often denied coverage in the middle category, and they sometimes denied people coverage if they had a history of acne or a hay fever, which would apply to many of us on this call. So somebody who was trying to get insurance on their own directly from an insurer would often face trouble getting coverage based on this way that private insurers try to make money in an unregulated market. Okay, so let me turn for a moment and pull back from this and talk about the system overall, because we have a mix of public insurance and private insurance, and each in different forms that is regulated in different ways. So if we look at the evolution of healthcare financing in this country, if you go back, just over 100 years, when people needed healthcare, for the most part, it wasn't a lot. There wasn't a lot of healthcare available. When they would use it, they would just pay for it. They would pay for it out of pocket. If they didn't have money, they couldn't get healthcare. And then what we saw starting in the early 20th century was we started to see prepaid health plans grow up, where you would pay in a certain amount at the beginning of the year, and it would entitle you to a certain amount of hospital care over the course of the year. And this happened as hospital care started to get more sophisticated and people actually wanted it. And so this is kind of the historical foundation of the Blues. And the Blues, Blue Cross and Blue Shield, were actually developed by the industry themselves, who were afraid that they wouldn't be paid if people didn't have a means to pay for healthcare, and also didn't want to have to determine who had the means to pay, who didn't have the means to pay, and to track them down to pay ahead of time. So then they created these prepaid health plans. And when at the beginning of the creation of these plans, they were built on kind of a model that looks more like that whole group of people who are treated equally. They were a more solidaristic model of health insurance. So everybody paid in the same amount at the beginning of the year, and everybody could use the same amount of health care over the course of the year. What we then saw happen was private commercial insurers started to come in, and they started to price policies based on individual characteristics. So they would look at the young, healthy people and say, well, we'll charge you less than the Blues are charging you. And they would pick off the healthier employer groups or the healthier people. And then the Blues were faced with a less healthy risk pool, and their prices had to go up, and so on. And so the notion of solidaristic private health insurance started to erode. Over time, then, we see building on this system, we see the growth through the mid-20th century of employer-based health care. And it was at this moment in time that a lot of other countries were turning towards public systems that were starting to develop, the British national health care system and the French system, and others were thinking about kind of a coherent and more seamless way of paying for healthcare. And what we saw first grow up was the employers as the locus for healthcare, and that has only strengthened over time. In the mid 1960s, a major development was the creation of Medicare and Medicaid. And what those programs really did was they filled in for people who didn't have access to health insurance through their employers. So Medicare is for people who are 65 and older, and then later for people with disabilities as well. And Medicaid is for lower income people. And often in its beginnings was for pregnant women and children mostly. And then over time, we've seen building on these systems. So in 1997, the Children's Health Insurance Program is like Medicaid, but for people who are slightly higher income than Medicaid's thresholds. And then we saw a number of other developments, regulatory. And then in 2010, we saw the passage of the Affordable Care Act. And what the Affordable Care Act did was it kind of tried to fill in the last gap. So we had a lot of people who had health insurance through their employers. That was pretty good. A number of people who are on Medicare and Medicaid, or Indian Health Service, or Children's Health Insurance Program, the Veterans Health Program. And if you didn't fall into one of those categories, it was quite hard to get health insurance. So the Affordable Care Act was trying to help this group and make insurance affordable and higher quality for people who were buying it on their own. So here's what the coverage sources look like in the US now. About half of people still have health insurance through their employers. About a third have health insurance through a public source, primarily Medicare and Medicaid. About 5% have individual market insurance, and the individual market is mostly, although not totally, these marketplaces that the Affordable Care Act set up for individuals. And 9% of the population under age 65 is still uninsured. And so let me break that down just a little bit further. So who are the non-elderly uninsured? So most people over age 65 have Medicare. So then who are those who are under age 65 who are still uninsured? As you go left to right, so most of them are in households that have one or more full-time workers. These are people who either don't have health insurance through their workplace, they may be part-time workers, or their employer might offer them insurance and their contribution rates are too high to be able to afford that insurance even when it's offered. The middle, not surprisingly, shows you that most of the people who are uninsured are in lower income households. So the federal poverty level for an individual is around $11,000 or $12,000, and so if you double that to 200%, we're talking, I think close to $25,000. Quadruple it, we're at $50,000. That's 400% of the federal poverty level. So it's that under 400% of the federal poverty level that is more likely to be uninsured. And then breaking it down by race and ethnicity on the right, you can see that that among the non-elderly uninsured, a large share are Hispanic and Black disproportionately. So if we look at that even a level deeper, what you'll see underlies, especially the Hispanic uninsured, is that a large number of people in that population are undocumented and have a hard time getting access to employer-based health insurance, are not eligible for the Medicaid program for low-income people, and can't get subsidies to buy insurance on the Affordable Care Act's exchanges. So who remains uninsured and why? This breaks it down just a little bit further. So the people on the right are people who could get help buying health insurance, but haven't enrolled. The Affordable Care Act gives people premium subsidies to help buy policies on the exchanges, and also expanded, which I'll talk about in a moment, the Medicaid program for lower income people. So the people in these kind of pie slices on the right are people who would be eligible for those public programs or who could get tax credits, who either haven't enrolled in the programs or for the tax credit eligible might not be able to afford coverage even with that help. These are people who earn more than the subsidy levels for those ACA policies, the darkest blue pie. Those people are getting subsidies right now because one of the relief bills, ARPA, provided enhanced subsidies for a period of time, but they're temporary. So we'll wait and see what happens over time. These are people who are ineligible for financial assistance because their employer offers them coverage that is affordable and adequate under the ACA's terms, and thus they can't get subsidies. And that's another piece that, that Congress might address in the coming year. We'll see. These are that 4 million people I was alluding to who can't get coverage because of their immigration status. And these are people who are in the coverage gap in states that haven't expanded Medicaid. So they're among the lowest income. They earn under 100% of the federal poverty level. Their state hasn't expanded Medicaid. And so, for the ACA subsidies start at 100% of the federal poverty level. So if you earn 100% or more, you can get help buying private insurance. If you earn under that, typically people would enroll in Medicaid if they're in a state that has expanded the program. So some people whose states haven't expanded that program end up in what they call the coverage gap. And so let me talk a little bit about some characteristics of private health insurance. So if we look at employer-based coverage, that 50% of people who have health insurance through their employers, it's the primary source of coverage in this country, but it's quite regressive, and it's regressive in a number of different ways. So the first is what you look at here is that the more you earn, the more likely you are to be offered health insurance through your employer, and also to be able to afford your share of that health insurance. Here, the premium rates and the contributions. So those of you who have had health insurance through your employer know this, is that your employer pays a large share of the cost of it, and you typically pay a share of the cost as well. And so if you look at those rates and the contribution levels, what you have to pay, they vary inversely by earnings. So as a percent, this is not surprising, right? If you have to pay $100 a month, if you earn more, it will be a smaller share of your total income. If you earn less, it will be a larger share of your total income. So for somebody earning under 200% of the federal poverty level, which is on the left-hand side here, the total combined premiums and the costs that they pay out of pocket when they use healthcare is on average 14% of their income. Whereas for a higher earner, it is only 4.5% of their income. So this aspect of health insurance is what has prompted Emmanuel Saez and Gabriel Zuckman to call it a poll tax. Essentially, everybody pays a flat dollar amount. And so for people, this is, as you look on the bottom, this is a complicated graph. But what you're looking at the bottom is the total population arrayed by income percentile, and then kind of the top 400 earners. And then, what are the tax rates? And so you can see for somebody who's in this kind of, middle income, that what they're paying in their contributions for health insurance and what their employer pays as well is actually a large share of their total household income for a year. But as you move up, that same, however many dollars a month is minuscule as compared to household income. And then as healthcare costs rise, the additional spending on healthcare is taking up more and more of total compensation, and it's eroding wages as well. So what you can see here is that employers have managed the growing cost of healthcare in a number of ways. One is increasing the share that individuals have to pay towards their healthcare. This is the deductibles. So you pay the first $500 or the first $1,000. Those are going up quite a bit, which means the out-of-pocket costs are increasing. And then premiums, the green line is the family premiums. How much are you responsible to pay a month? They're going up also, at a fast rate, much faster than the workers' earnings and overall inflation. Okay, just a very brief moment on public health insurance, just for some background. So Medicare and Medicaid are the two key public health insurance programs, the two largest public health insurance programs. And they pay for a larger share of total national healthcare costs than the portion of people they insure. So you can see here that they're about a third of total the total population covered, and they pay for a larger share. If you look at this has other public in here as well. They pay for a larger share of total costs than the number of people they cover, even considering the fact that the actual rates they pay for each unit of care is less than what other sources of health insurance cover. Medicaid is the program for lower income people. As I said, Medicare is age 65 and older, and people with disabilities. Both are considered public programs, but they're actually quite different in nature. They are both government financed, although they are financed in different ways. And Medicare is not fully government financed because people pay premiums towards their Medicare policies as well once they enroll in it. And they also pay for part of the costs of care often when they use care. And so, even within the public programs we have in this country, there is different flavors of public health insurance. Now, Medicaid in particular has been a major success story of just coverage in general, going back historically, and of the Affordable Care Act as well. If you look historically at before the Affordable Care Act, the way the Medicaid program worked is it's health insurance that is run by the states, but it is state and federally funded. So there's a federal match called the FMAP, where the federal government pays a percentage of total healthcare costs for people who are enrolled in Medicaid, and it's more for states where there are higher levels of poverty, lower household income, and the eligibility before the ACA was called categorical eligibility. So it wasn't enough just to be poor, you had to be poor and those ands included that you could be under age 18, you could be a pregnant woman, you could be a person with a disability, and also low income. And it covered about 46 million people before in 2010, before the Affordable Care Act went into effect. After the Affordable Care Act, it was still a state program. It was still state and federally funded, but the Affordable Care Act said, what it said initially was that states have to cover everybody now, everybody earning up to 138% of the federal poverty level, regardless of what category they fit in. And for the first few years of that implementation, the federal government said, we'll pay the full cost. And then after that, for a period of time, we'll pay 90% of the cost. States, you pay the other 10% of the cost. As those of you who are law students now know, if you've taken constitutional law, this was one of the pieces of the Affordable Care Act that was challenged. And in this challenge, the Supreme Court said that when the federal government said to the states, you must expand, and if you don't, you will lose all of your federal Medicaid funds, that was not a proper use of the tax and spend clause power that they have. And they said it was coercive. Robert's language was like it was a gun to the head of the states. And thus the opinion rendered the expansion optional. So states could expand, and if they expanded, they would get those additional federal funds, or they could keep their programs exactly as they were before. Now, even with some states not expanding, this has still been a huge piece of the Affordable Care Act's coverage gains. It's been a huge success. About 12 million or more new people have been added, but even more would be and may still be added as more states consider expanding. This is a quick snapshot of what expansion looks like, what it looks like now. And actually just this week, there have been some developments in this regard. So 39 had adopted, including some of these states that have adopted by ballot initiatives. So you can see that that there has been both organization on the ground and also an expression of the value of the Medicaid program through ballot initiatives, where people in states like Oklahoma, where the legislatures and the governors have failed to expand the program, have passed ballot initiatives saying we want the program expanded. Oklahoma this week just expanded. Missouri, the state government is still resisting expansion, and a recent court decision has said that the ballot initiative is not binding on the state if the legislature doesn't pass the budget in order to be able to fund the expansion. So we'll see what happens there. Okay, so how does this compare to other countries? I'm not going to go into a full comparative view, and a lot of you know a lot more about the health financing system in other countries than I do, but this is just the bottom line snapshot, is that with this system, which is also often called a fragmented system of how we pay for healthcare, we spend about twice as much as our similar peer nations. And so this is, percentage of GDP spent on healthcare, and the U.S. spends, data is a little old now, we're even higher than this now. At this moment in time, the US was spending about 17% as compared to an OECD average of 8.8%. And you can just see the gap that has increased over time between us and other countries. And so that might be okay if we had tremendous outcomes, if we were spending a lot of money on healthcare and we were the healthiest country in the world. As I'm sure you can imagine, that is not the case. So here's just a quick picture to say that we spend more on healthcare and we get less for it. So as you look at this picture here on the x-axis, as you go rightward, you're seeing healthcare spending per capita. And as you go up life expectancy in years, you could do this same picture with other parameters, infant mortality, subjective health status, many other dimensions. And what you see is that we're way out here, right, on spending, and we're below all of these other countries in terms of life expectancy. So what drives this? So what drives our spending, first of all, is not utilization. We use about the same amount of care as other countries do. It is our prices. We pay more for every unit of care that we use. And what drives our poor outcomes is a mix of spending on low value care and also the picture that I showed you a moment ago of the fact that still, 10% of our non-elderly population is uninsured. And so that if you average health outcomes and you average life expectancy and 10% of your population is uninsured and can't get access to health care, then you get worse life expectancy on average. There's also a lot of other factors that add to that. There have been some really interesting studies showing how racial bias in healthcare has led to things like worse infant mortality and maternal mortality for Black women, and a number of other dimensions as well. So it's a complicated story, but those are some of the big pieces of it. And this is just to show the prices. This is the US for a number of different procedures, is the little red bubble that's out here on things like an angiogram. You see the US is way out here. The gray bubbles are Argentina, Canada, Chile, India, and the blue bubbles are France, Germany, Spain, and Switzerland. This is actually an interactive that you can play with. It was by Ezra Klein, so you can Google it and find it and play with it. You can touch on each one of them and see which of the countries it is. But the point is really just that we pay more for all different kinds of units of care than other countries do. Okay, so why is this happening? Why haven't markets worked to ameliorate this problem? Why is antitrust law not fixing it? Way more than I could cover in the next short bit of time, but let me just at a very high level talk about a few pieces of that. Why markets don't work. So why are we not seeing competition drive down prices, for example, in healthcare? There are a number of reasons, but a few of the big ones are that if you think about other areas where competition may work better, you have people who can make smart decisions between options if they have those options, right? So if you get the right number of competitors, or you have a healthy competitive field, then people may be able to navigate those options and choose among them. And in healthcare, even if there were that kind of array of options, it's really not the case. So it's not the case because of what healthcare is. Healthcare is not the kind of good that people look at and they say, well, I feel like I might be having a heart attack, but I'm not going to go to the hospital. I mean, people do actually do that if they don't have health insurance and they can't pay for healthcare, but they shouldn't be, right? And so often people are making decisions to spend money, whether they have it or not. They're using credit cards, they're mortgaging their homes, they're doing other things because healthcare is life or death. And often it's emergent. People show up in the emergency room and they're given care and they're told they need X, Y, and Z care. And so they're not going to look for and shop for different alternatives at that moment in time. Both healthcare and health insurance are also extremely complicated and specialized. So people don't really know if they're looking at, myself included, I've had to make these kinds of choices. A doctor versus B doctor. Is B doctor worth more than A doctor? Looking at insurance plans. How do these plans really differ? Who's in each of these networks? How much am I really going to end up paying? These are really complicated decisions that most people have a really hard time navigating. In many cases, patients, insureds don't have negotiating power because they're bound to terms that other people have provided to them. Your employer offers you a plan with certain terms, and that is your health insurance, and that's the doctors you can go to, and those are the prices you will pay. Or your insurer has created a network for you, or they've negotiated rates for you. And these proxies, the insurers and the employers, they lack the incentives to get you the best deal. They can pass off the costs in many cases. And they lack the power in the market as well to represent the patient, the end, insured's interests, because the providers, the hospitals and the doctors have become extremely consolidated and can really name their prices at this point in time. So this is something Amy mentioned in the outset, and it's something that is really plaguing healthcare right now, is the fact that the provider space, the hospitals, the doctors, the ancillary providers, the labs and other services have become so consolidated that they really have an outsized amount of market share, and it is still growing. There's increasing consolidation following the pandemic, which weakened some of the smaller hospitals, which weakened certain physician groups. And so you're seeing more and more of this kind of buying up of and gathering up of these smaller providers by the larger ones. So why has this happened? This is also a complicated story, but some of the big pieces are the fact that, as you've heard in other sessions, there were a number of decades where antitrust enforcement was lax, and the courts pushed back on the FTC and the DOJ's efforts to stop mergers, especially hospital mergers, and so that has, that kind of that created a really strong start to the consolidation that has continued. Now, in the healthcare space, even if antitrust had been working perfectly, consolidation would have still happened. And this is in the Berenson article that I have given you to read, talks about all of these different ways that consolidation and market power creates, even in spite of good antitrust enforcement in the healthcare space. And it's because the kinds of things that antitrust regulates aren't necessarily the ways that providers gain power in this space. So you see things like consolidation across geographies. One example in that article is that the UC hospitals in California and the University of California hospitals negotiate together, and so they're able to, even though they're not a large market share in any one geography, or too large of a market share in any one geography, they gain power in different kinds of ways. Even in their local geographies. And in Los Angeles, UCLA is what's called a must-have hospital. It has some of the best specialists. It has some of the most top-notch services. And if you're working for a large company in Los Angeles, and that company is not providing you access to UCLA's hospitals in its insurance plan, you would object to that. You would say, I need access to UCLA's hospitals and doctors. So much so that a number of years ago, one of the insurers tried to push back on UCLA for its rates and said, if you don't bring your rates down, we're going to drop you from our network. And UCLA said, fine, drop us. And of course, the insurer had to reverse course on that one, knowing that UCLA had to be, in its network offerings for it to maintain many of its employer insureds. And then in the provider space, so if you think about doctors, there was a case that looked at when doctors were joining together in networks to jointly negotiate prices. And it said if doctors are joining together, it's called Maricopa. If doctors are joining together and what they're doing is jointly negotiating prices, that's price fixing, and that's per se illegal. And then following that, and this was at the beginning of the creation of what are called managed care organizations. And managed care organizations were insurers where they would essentially have a group of providers who would be part of their network, and they would say to the providers, they would say to the providers, if you give us a lower price, we'll guarantee you a flow of business. So this was at the very beginning of that, and these doctors were joining together to create a network to be the basis of that kind of organization. But what they were doing was joining together and setting prices. Court said per se illegal. And then in the years following that, the FTC and the DOJ put out guidance that made a ton of exceptions to provider networks. And they said things like, well, even if you're jointly negotiating prices, if you have financial integration, so if there's some kind of financial risk here, you're getting $100 per patient, and if you can manage their care really well, you can provide them really high quality and efficient healthcare so that it costs less than $100, you get to keep that extra money. And if it costs more, you have upside risk, and you might lose money on this patient. So you have the incentive to provide a good quality product. Then we're not going to scrutinize you as carefully. So there are a number of these other exceptions and safe harbors that were put out there that kind of blessed this kind of integration. And part of this is because integration is really tricky in healthcare. So you want coordination in healthcare, you want coordination among providers, but the more you get coordination, whether it be among a group of doctors or among hospitals and doctors, the more power they get and the more it drives up prices. So that's what we're seeing in the space now, is we're seeing that doctors used to be independent entities. More and more they are salaried by and working for hospitals, and these entities are getting larger and larger and gaining more and more negotiating power. in a way that does not necessarily run afoul of antitrust law. So where does that lead? And I should say that they're powerful enough that even when you look at some of the strongest negotiators in this space, so you look at the most powerful, employer groups who are trying to push back on prices, or insurers, they don't have the ability to do so. So recently, JP Morgan Chase, Amazon, and Berkshire Hathaway formed a new venture haven to try to do something great in the healthcare space. And then after a very short period of time, it folded for a number of different reasons. But one of them was that even these behemoths couldn't push back on the large provider groups to get the kinds of prices that they would have hoped to get. And so private insurers reimburse about twice as much as Medicare does, right? Medicare, public insurance, they set the rates. They represent and insure a large number of people. And so most hospitals and most doctors take Medicare patients, and private insurers pay about twice as much as what Medicare does for care. I'm sure you have heard the rhetoric that they can do that they can take these rates from Medicare because they are able to even that out, average it with the private insurance rates. And so it's the high private insurance rates and then the lower Medicare rates together, which enable them to kind of make ends meet. Hospitals, the other way you'll hear this is hospitals lose money on Medicare, but it's actually not the case. So if you look at until recently, relatively efficient hospitals broke even on Medicare rates. Now they almost break even on Medicare. Less efficient hospitals don't break even on Medicare, but maybe they should become more efficient to do so. But even when they don't break even on Medicare, the amount that they're losing on Medicare patients is way below the additional amounts that they're making on private insurance patients. Okay, so where do we go from here? If markets aren't working, if antitrust law can't fix it, what are the alternatives? So let me very briefly just talk about 3 flavors of ways that we could see public health insurance expanding in this space. So the first is, and I'll map them out for you first. So there's the idea that I'm sure you've heard about if you have watched the health debates at all, is the notion of the individual public option. And I've mapped these out on the space from left to right. Down here is from incremental to sweeping, and from less equitable to more equitable in terms of the total system. Is this creating a more equitable healthcare system, or is it just kind of picking around at the edges of the system? And so the individual public option is an idea that's very incremental, and it is not going to promote a more equitable system. An idea that I'm working on now is called an employer public option. It's somewhere in the middle. And Medicare for all, a single payer system, would be sweeping. It would be a huge change, moving everybody onto Medicare, but it would create a more equitable system at the end of the day. So the individual public option is, it grows out of many years of promoting the idea of choice in healthcare. And when it comes to the idea of choice, it goes back a number of decades, and it came from a lot of different roots. So we could see the roots of healthcare growing out of sources like the Universal Declaration of Human Rights and the pro-choice movement and the disability rights movement. And at the same time, it has also been a neoliberal tool. And in healthcare, it's kind of grown from both of those spaces at the same time. So it's a really complex value with complicated origins in the healthcare space. Now, choice when it comes to health insurance, it feels far from empowering, right? It doesn't feel like choice over control over our body or autonomy. It feels like looking at a lot of complexity and trying to figure out without necessarily understanding all these different pieces, what is the best option? This is just a snapshot from Covered California, from one of these ACA marketplaces. And I have my students try to buy a plan on Covered California. And what most of them who are pretty health insurance literate see is that navigating these options is really hard, even when you understand the basics of health insurance, even when you have some sense of what you care most when it comes to healthcare. So the notion of an individual public option is based on the idea that if you give people, and the public option that's being talked about now is putting a plan that is likely based on Medicare into these ACA marketplaces so that somebody could choose either a private plan, the private plans that are offered now, or they could choose a Medicare-based public option. And the idea, the kind of theory behind this idea goes back to many decades, the 1970s, to this idea called managed competition, which was developed by a Stanford economist, Alan Entevin. And his idea was that if you give people in a regulated marketplace, which the ACA marketplace is, the option of a number of different plans, they will pick good choices among plans. And when they do that, the other insurers will notice, they will change their offerings, and it will begin to transform how we pay for healthcare and how we deliver healthcare as well. So he imagined plans that had really good primary care providers that could help to manage all of your care would be the ones that won out. And when people chose those plans, which would give good care in a more efficient way, that it would transform kind of the state of over-reliance on specialists and hospitals and make for better healthcare delivery in the long run. It is a really nice idea and concept. It does not work that way in practice for a number of different reasons. And the reality is it goes back to that navigating the health plan options that are out there, is that people, regardless of education level, make poor choices among health insurance plans. It's really hard to be able to navigate those kinds of options. And even if you try to help people, there's been a lot of efforts to try to nudge people using decision support tools towards better choices. People still resist it. So one of my favorite studies is by one of my colleagues at Penn, Tom Baker, and it showed that people have even odds at choosing an objectively best plan among options. And the only thing that actually made for a better outcome was defaulting them into the right option, and then giving them a number of other things like a cost calculator and information education around it. But you had to default them into the right option in order to improve that decision making, at which point you have to ask, what is the choice in these kinds of marketplaces actually doing? The choice of health plans, those of you who have had to do it in open enrollment know this is something that makes people miserable. People enjoy it. They say about as much as doing their taxes. And it doesn't change the basic structure of the market. So it's still, even if you insert a public option into the ACA marketplaces, the basic idea that if you just get the right competition, we can improve the system, is kind of still undergirding and underlying the structure of healthcare and health insurance. And so what that means is that it continues to elevate this notion of choice. It continues to promote the idea that choice is doing something valuable, that we should revere choice in this space. And then it feeds back into these choice elevating policies, even if at the end of the day, they're not producing the kinds of benefits that the theory says that they should produce. So it's not necessarily a bad thing. There are some marketplaces in which there are not enough private plans being offered, and it will provide people in those markets an option if they don't have one. There are some markets where there are only one and two plans, although fewer over time. And in those, it could help a little bit with price, but it is not going to transform the system overall. The question that I'm asking in current work is, could we harness the idea of choice to catalyze more structural change? So I'm working on a new project on an employer public option with Howell Jackson at Harvard and Amy Monahan at Minnesota. So how is this idea different? So the basic concept is that we would offer a public option at the employer level. So offer employers the opportunity to essentially buy into the Medicare program, to offer their employees Medicare instead of their private plans, and to offer just that as their employee health plan. So not giving employees lots of different options, but instead choosing Medicare for their employee health plan, and all of their employees would then be enrolled in Medicare. It would have a lot of benefit for both the employers and the employees. Employers are really struggling, as I mentioned before, with escalating healthcare costs. So they could both benefit from Medicare's prices and Medicare's vast network. And we think this idea could be a good one, because employers are better. They have whole infrastructures, HR teams, to navigate health plan choice, especially among large employers. So they could look at Medicare and say, we think, this year, next year, in the long run, this is going to be better for our employees and our business. It makes for a better fiscal case than Medicare for All does. So if the employers are paying in some money towards the plan, that doesn't show up on the fiscal books. It's not part of the total budgetary cost of the plan. So it could, we think, make it less of a political non-starter, still challenging, but less of a political non-starter as a way to kind of expand out Medicare. It could expand out Medicare in a meaningful way. As I said earlier, half of the population has an employer plan. If even just a few large employers were to buy in, it could enroll a large number of people in Medicare. It could test out the idea, refine it, and build over time. And then if a number of employers were to buy in, what you would get is a more seamless system. More people would be on the Medicare program. It would provide portability from one job to the next. And over time, as people get older and then, are in that older over 65 age, where many people are enrolled in the Medicare program as their primary coverage. So the question motivating this here was, could you take the idea of a public option and make it something more transformational? And then obviously the most transformational idea is Medicare for all. If you talk to most people in the space who are experts on financing, who are experts on the US healthcare system, they would say this is the right solution. Medicare for all is the right solution. It is more efficient, it is more equitable, and it is really hard to get to from where we are now. So the basic idea of Medicare for all, or a single payer system, the government finances the care. It sets the rates, it pays the providers. The providers have just one place to bill. They don't have to bill, dozens of different insurers. And the providers can be either public or private. It doesn't change the hospitals or the doctors in that kind of way. It is usually largely tax financed. There are equitable benefits, contributions, what people pay towards it are also equitable. They're usually based on household income, usually produces universal coverage. So Medicare for all is just one version of this kind of single payer system. It is not socialized medicine. When people call it socialized medicine is in other countries, in a not derogatory way, referred to systems where the insurance, the financing, and the providers, the hospitals and the doctors are all public. They are all government salaried and government run. This is the government paying for the care. So why has this not happened? So first of all, Medicare for all suffers from sticker shock. No matter how you estimate those costs, this is a lot of different estimates on Bernie Sanders' version of it. It is quite expensive, and it is all on budget cost. It is all money that has to be raised through taxes. It all shows up on your CBO score. It is really expensive, and so even if it is, at the end of the day, a less expensive system, even if we would pay less on healthcare overall, it is all federal budget spend, which makes it politically challenging. What also makes it politically challenging are the powerful vested interests in the healthcare space. So among the top highest spending lobbyers in 2020, this is just the third quarter, include pharma, American Hospital Association, Blue Cross Blue Shield, American Medical Association. They rise up the list when there are more contentious healthcare issues like the ACA at play. And then one of the greatest challenges to thinking about Medicare for all, and this will be my last thought, and then I will stop here, is that if we think about Medicare for all as a private healthcare system that could build something tax financed and more equitable, as a public healthcare system that could build something more equitable, Medicare itself is becoming privatized right now. And that is happening in some obvious ways and some less obvious ways. So the most obvious way is that there's a piece of Medicare called Medicare Advantage, which is Medicare run by private plans. The government gives a private plan a certain amount of money per Medicare enrollee, and they then manage the care. They tell that person what doctors they can go to, often a smaller network than for what is called traditional Medicare, public Medicare, and they tell them what care they can use or not use. They do more of this utilization review that can help, in theory, direct people towards care that they need. And in worst case scenarios, and some evidence is suggesting in real case scenarios, is denying people necessary care. So this program, Medicare Advantage, is very quickly growing as a share of total Medicare enrollees. So this is the most obvious way that Medicare is being privatized. And it's growing even despite evidence. It's been in existence for decades now, and it is unproven. There is not evidence that it saves money or provides higher quality care, but it is still something that regulators have doubled down on and that people are enrolling in. And then there's a lot of privatization happening in Medicare in less visible ways. So there is a group called Medicare's Innovation Center, or CMMI, that runs demonstration projects in Medicare. And a lot of what they've been doing is testing out different partnerships with private entities and testing out these kinds of relationships where, similar to Medicare Advantage, a physician's group or a hospital gets a certain set amount of money to take care of a group of patients for a period of time. And if they can save money and provide good care, they get to benefit from some of the upside savings. And then in some cases, they share in the downside risk at all. But all of these programs are injecting private players in key decision-making roles around where people can go for care and what kind of care they can use that have historically not been part of public Medicare. So if what we're trying to do is build out public health insurance to create a more equitable system, that is only becoming more challenging over time as Medicare privatizes. So for those of you who are thinking about reform in the healthcare system, for those of you who are thinking about how building out, public programs in particular can serve certain values and goals, I encourage you to reckon with some of the on-the-ground ways that these programs are changing rapidly and what can be done to push back on some of that influence. So that was a lot of information. I will stop there. I look forward to seeing you all in person soon and getting questions from you as well.
Thank you so much, Allison, for that wonderful and rich introduction. So it really puts us in a good place, I think, in our in-person discussion to think about commonalities between this area and others, and how some of the what we've been calling sort of neoliberal and kind of market supremacist ways of thinking about organizing our law and politics have set us up for some of the concentration and the distributive problems that now kind of loom large. And also, one of the things we've been talking about is how these political dynamics, sort of inherent in the term political economy, is that these problems are political as well as economic. It means a number of things, some of which is about the political dynamics and the difficulties taking apart the systems that we've designed. And so that's written all over the health insurance space. But also importantly, that some of these conversations can't be kind of tamed by just calling them efficiency problems. And in fact, so part of what you beautifully illustrated, I think, is how much our political values are at stake. Do you want a health insurance system that is distributive or not? Those are really the sort of deep conflicts that underlie conversations about how much we're spending on healthcare and how efficient our system is. So we'll talk more about that in person. So I'll take it over now and talk a little bit about pharma, which will hit some of the same themes, but also in certain ways is a very distinct legal and regulatory environment. Okay, so pharmaceuticals. So very much like what Allison just described with respect to healthcare, there are major kind of policy concerns in this area today, and they sound some of the same notes. Very high costs and concern that we're not getting good things for that spending, and that Americans are suffering because of the way that we organize the political economy of pharmaceuticals. So I'll throw up some slides here too to show you some of the way this looks in the pharma space. This is a 2019 survey from Kaiser that shows that as of that time, 29% of Americans reported that they had not taken a medicine as prescribed because of its cost. And you see here in the next slide that they also in the same period showed that that 24% of Americans had difficulty affording the cost of their prescription medicines, and that if you dig down into those details, that it's 35% of those earning less than $40,000 annually. Okay, that's not actually so surprising. And of course, there's also disparities with respect to how healthy people are and also their age. This is even more, in a way, dark picture. And this is not just pharma, but also healthcare. This is a Gallup poll asking, has there been a time in the last 5 years when a friend or a family member passed away after not receiving treatment for a condition due to their inability to pay for it? And again, this might be pharmaceuticals, it might be other kinds of treatment. And it shows how many Americans, 13% of them, who report knowing at least one friend or family member in the last 5 years who died after not receiving needed treatment because they were unable to pay for it. And of course, disparities here too. So among non-whites, over 20% here report that. So the racial disparities are very clear, and also the income disparities are very clear. 18.5% of those under 40,000, earning under 40,000 a year, report the same thing. Right? So this really is the kind of life or death set of questions that we're talking about today. So one of the other trends that we see in pharma, as we've seen in other areas, is rising costs. So I'll get into what's on the slide in a second, but just to back up and sort of speak more generally for a second, US pharmaceutical spending per capita, like as you saw in the general healthcare context, is higher than any other OECD country. It was not 1.9% of GDP and about $1,200 per capita in 2018. Right, so that's just pharmaceuticals. Prices have risen steadily and are projected to continue to rise. And the prices of new medicines are really eye-popping, especially new medicines in classes for which there aren't other good available treatments. So one new medicine approved in 2020 has the distinction of being the most expensive medicine currently in the United States. It's called Zokinvi. It has a list price of $86,000 per month, which translates to more than $1 million per year. That's a big price, especially when you consider what Allison described as people who are, of course, uninsured, but then co-pays and other forms of employee contributions to healthcare. So your premiums are going up, your co-pays, your co-insurance are going up, and people are paying quite a lot out of pocket. And more devastatingly at a systems level are drugs that are not for rare diseases and small patient populations like Zokinvi, but drugs like the new Alzheimer's drug. Some of you may have read in the press recently that was just recently approved very controversially by the FDA against the advice of its expert advisory group. There is no, unfortunately, good evidence that this even works, and there are some real signals that it causes things like brain swelling in some of the clinical trials, so that it has serious side effects. But of course, there's no good treatments for Alzheimer's, and so there's a lot of pressure on the agency to approve this. That drug will cost $50,000 a year. And its impact, because the number of people with Alzheimer's is so large in the United States, and because somehow inexplicably the FDA also approved this for a very broad kind of many stages of the disease, despite, again, the sort of evidence base, this drug costs $50,000 a year. And here's the New York Times on how this impacts spending for Medicare. So Aduhelm, this new Alzheimer's drug, is expected to dwarf the estimated cost of already the 10 costliest drugs once it is being fully prescribed. And not only that, but just the spending on this one drug alone is projected to be more than the United States spends on NASA, on the National Science Foundation, the CDC, right? We're talking enormous, enormous sums, in this case, unfortunately, for a product that very likely doesn't help and, in fact, may do some harm. So we've also seen some substantial price increases for older drugs, and probably you've seen this in media, right? That diabetes drugs, for example, diabetes is a very common disease in the United States, affects an estimated 10% of Americans, including 1.6 million who have type 1 diabetes, which means they need insulin every day, or they risk serious repercussions, even death. Here are some few facts about insulin gathered by a really terrific activist group called T1 International, people living with T1 diabetes. And you can start to see some themes here, right? So it's a concentrated market. There's the big three insulin producers produce more than 90% of the market by value. The cost of insulin has increased dramatically, especially in recent years. And this is despite insulin itself having been discovered many decades ago, and the newer forms not having changed substantially despite these, or in some cases, not at all. They've changed not at all, but the prices have gone up hundreds of percent, as you see here in these figures. And as you read further down into this list, you'll see that patients are, of course, then also, with the way insurance is going, paying more out of pocket. And part of the result of that is patients are rationing their own insulin. And when this leads, of course, to higher healthcare costs for all of us, because if they end up in the emergency room and with amputations or other consequences of uncontrolled diabetes, that raises healthcare costs for everybody. But also, there are people now who are dying in the United States because they cannot afford or are rationing their insulin, and we have good evidence of that, unfortunately. And this is an old drug, right? And so what's going on here? What is actually causing the problem? I want to say that at some level, when you read the debate in public, there's a real confusion that we would like to kind of cut through by talking about this in the ways we've talked about it in our course. This is another kind of slide from Kaiser, and when they ask people, do you want to deal with drug prices by market competition or government regulation? It's sort of at some level, that's a coherent statement, but of course, at another level, that's not a coherent statement, right? So people, as sort of Democrats, seem to like government regulation more than market competition, vice versa for Republicans. But at the bottom here, what we have is a system that there is no free market, right, in medicines. Why is there no free market in medicines? There's no free market medicines there's no free market anywhere. We've talked about that, right? Law undergirding the market. But that's particularly the case when we're talking about pharmaceuticals. And let me tell you why here. And I'm actually going to stop the share because I'm done with my slides now. So there's no free market in pharmaceuticals. Well, what does that mean? Very particularly, it means that in fact, there are behind the power that companies have to set prices like $1 million a year for a drug lies the government, right? Because the government gives patents. What is a patent? A patent is a temporary right to exclude all others from something which is ostensibly new and innovative, non-obvious, and useful. And so you apply to the government and the government gives you a right, and then you prevent others from being able to sell into the market, right? So it is in some sense by definition a monopoly. And economists will tell you it's not necessarily a monopoly because there might be competitors, but of course healthcare is a space where part of what Allison's describing to us, what we've been talking about already, is that there's actually often a lot of sensitivity to even very modest differences in healthcare, because our willingness to pay for something like an additional couple of months, even days of life may well be almost infinite, right? We're very sensitive to differences and so there's often, in fact, real monopoly power given by these patents. There are also regulatory barriers. You have to spend quite a lot to show that drugs work, to know that they work. And so those regulatory filings then have been the pharmaceutical companies enjoy exclusivity that mean that, for example, they spend this money on the clinical trials. And even though we can show that a drug actually is the same as another drug, so chemically speaking, you're not allowed to register it under the knowledge that it in fact works the same way for a certain number of years. It's kind of like a patent, but it's called a regulatory exclusivity. And we've gotten those, and they've gotten stronger over the years. There are also trade secret barriers in this context. And so why can't everybody make COVID vaccines all around the world? There are patents certainly in some places, but we don't even know what the patent landscape looks like for COVID vaccines because patents can remain secret for a period of time after their filing. And so we don't even know what's out there in the patent landscape, but we do know that companies hold close, very close, their know-how about how to do things and refuse to share with others, and that creates barriers, of course, also to the scale up of manufacturing in this context. An overwhelming part of the high cost of medicines is the monopoly problem. So the cost of production in pharmaceuticals tends to be quite low. It's really remarkable when you start to get to the figures of how much does generic competition bring prices down. One of the things that we saw, for example, in the HIV/AIDS crisis around the world is that medicines that cost not only in the United States, but often in other countries too, $10,000 or $15,000 a year, prices which seemed really high in the 1990s when we were talking about this and really fighting these fights on the global scale, could be made for $100 per person per year. So 1% of the cost, it would be not an uncommon relationship between the actual cost of production and the markup that is enabled by the lack of competition. So high prices are sustained by barriers to entry. And it's the high cost drugs that really are driving the spending. So even though brand name drugs are only 10% of the prescriptions in the United States, they are about 75% of drug spending. In the generic context, you've heard me say some of these older drugs are expensive too. I don't know if you remember Martin Shkreli, the pharma bro, but he essentially sort of figured out how to jack up the prices on old drugs because there are some regulatory filings necessary there too, and it takes a year or two to really ramp up a new generic and bring it into the market. And he just sort of arbitraged. These are sort of finance guys who figured out that they could jack prices up very substantially and sort of pull some money off the table in ways that benefit them, but of course have no public benefit whatsoever. These are old drugs. They didn't get more valuable. Because Martin Shkreli figured out that he could extract some money from the healthcare system by jacking the prices up. So the problems really in the pharmaceutical space are very much organized around monopoly. And what's interesting about this is that when you look at it, as with public health insurance too, which is a very heavy government component, here there's a very, very heavy government investment. There's massive amounts of government investment into R&D, particularly riskier kinds of R&D. We do, though, give firms over a central role in evidence production. And that, I raised the Alzheimer's example, not only because it's very timely, but also because it illustrates another problem with the kind of concentrated power that private industry has in this space, which is they have lots of reasons to create evidence that shows that their drugs have some benefits. And what they did in the Alzheimer's case is, if any of you are familiar with statistics, there's lots of ways that you can sort of slice and dice data after the fact to try to show that your drug has had an impact. In that case, not on some of the outcomes that they thought initially, but on some other outcomes, right? Some people call the kinds of things that pharmaceutical companies do in this space data dredging or p-hacking. Like, there's ways in which, if you know how to manipulate data, you can sort of find good results, or in fact, in advance, design your trials in such a way to show that things have more benefit than they do. So there's that sort of problem, which is also deeply baked into a system with lots of private power. Like, who's going to be showing the negative evidence? Regulators try to suss it out, but of course they're under lots of pressure too. And the approval of Aduhelm is an example of how they have yielded to that pressure. And that pressure doesn't come only from industry, it also comes from patient groups, which of course are quite eager for new treatments and have put a lot of pressure also on the agency with the theory that they'll bring faster cures to market. All right. Another issue here is that we really don't have a system in the United States of any kind, and this is unlike much of the rest of the world, at least the wealthier world. We don't have any system of price controls, and increasingly we have mandates to cover, and that is part of the expansion of health insurance. It's a good thing, but you add monopolies plus mandates to cover, and what do you get? You get explosion in prices. In fact, behind all of this is a neoliberal policy framework where we had sort of narratives in the courts and in Congress about the need to compensate for R&D and the enormous risk that has kind of dialed down some of the requirements of patent law, for example, that the standards, well, is it really obvious? And, sort of were dialed down in the 80s and the 90s, for example, became easier to obtain patents. We didn't use antitrust law to police the abuse of patents, in fact, made it harder to use antitrust law to do things like police the abuse of the, by creating thickets of patents, or what's called pay for delay, where companies at the end of a patent life would actually pay off people who were coming into the market to make sure that they didn't come in too soon and lower the cost of the drugs. So antitrust law could have been used to police those things, but was not. And we have a narrative generally that really emphasizes the value of innovation without really emphasizing also that innovation comes at a cost sometimes to distribution, and that there could be, in theory, trade-offs between, not just in theory, but in fact in good economics, there's trade-offs between innovation and equity, and we should be thinking about those as real issues for our healthcare system. There's also an enormous amount of gaming. Sorry. I'll recover, I promise. Okay, there's an enormous amount of gaming of the system that you've heard a little bit when we talk about that with respect to the Alzheimer's drug. There's a wonderful expose actually about some of that on Stat News about the Alzheimer's drug and sort of pressure on the FDA and these moving of endpoints. But there's also things like simply the creation of Me Too drugs, so drugs that are exactly like the old drugs. So if you are in the industry, you have, there's lots of reasons in your private incentives, instead of doing really breakthrough, innovative new research, do a drug that's a lot like one of the other drugs that's already out there, because you know that the model can work, it's a druggable problem, and you can tweak the molecule a little bit and put your own version out there, perhaps, or an analog of that version, and then just compete away the market share. And that is what a lot of the innovation we have looks like. So there's actually good evidence that we are not getting enough risk-taking from the industry as it's currently oriented. And of course, the industry spends a lot of money on lobbying to lower regulatory standards and get extensions on its patents and so forth, and to impose US standards on the rest of the world. There is also some evidence of consolidation at the level of the industry, and evidence also of predatory buy-ups of companies. It's sort of dynamic, where my colleague at Yale, Florian Ader, has written about this in a paper about killer acquisitions, where companies buy up competitors who are innovating in their space to kill off the competitors before they can cannibalize their markets. All right, we've gone on for some time, so I'll just say very briefly, and we can talk about it more in the course. What could be done differently here? Well, fundamentally, one way to think about the alternatives in this space, like Medicare for All, is more public influence over the system. We have a system where we have essential goods, where we in fact know kind of what we want. We can measure it, and people in health are measuring it all the time. So we should pay for things, as other countries do, that have therapeutic value. That would in fact change incentives to have fewer Me Too drugs, drugs with more value, more breakthrough innovations, and in fact also potentially influence. We have no system really for controlling how much we pay for this Alzheimer's drug, even though cost benefit analysis would suggest that we should pay a lot less for it than the $56,000 that the company is charging. So price controls that could help set innovation incentives could be part of it. Also more public R&D. So we already pay for a lot of basic R&D. We could pay for more that's further upstream, perhaps solving some of the problems of the massaging of evidence, as well as creating a platform that would enable us to lower prices and improve innovation by directing investment in things that we think are really valuable, that could include, of course, global health problems, which are neglected until they're a crisis, as with everything else. Okay, so I think I'll stop there, but just to say a kind of way to bring together some of these two things is to, and with our themes in AMRI, is to think about where we have essential goods. Such incredible complexity, network effects, and information, sort of information economics dynamics, very high fixed costs, but then very low marginal costs. It seems fairly straightforward that we're going to need to sort of move toward a more managed form of provision of these kinds of services. And the alternative to that is, in fact, monopoly power. When you run that up against mandates for provision, you end up with a pretty unsustainable budgetary implication, and also one that turns out to be quite inequitable. So we can talk more about that in class, and thank you guys so much.